In 2002, the prescription rate for hormone replacement therapy fell off a cliff. It dropped by 80% almost overnight. The trigger was a July press conference and subsequent publication by the National Institutes of Health. They were announcing the preliminary results of the Women's Health Initiative, or WHI. This was a massive undertaking, a $1 billion trial tracking roughly 160,000 postmenopausal women. More importantly, the WHI was designed as a randomized controlled trial. In evidence-based medicine, this methodology is the accepted standard for proving direct cause and effect. The investigators halted the trial early to issue a severe warning. Estrogen plus progestin therapy increased the risk of invasive breast cancer, heart disease, and stroke. Up to this point, decades of clinical and observational data had consistently indicated that estrogen protected the heart and blood vessels. But the perceived authority of a large-scale randomized trial overrode all prior clinical experience. Within weeks, avoiding hormone therapy became the definitive medical consensus. Yet, over the next 2 decades, the very researchers who authored the WHI systematically retracted those initial alarming claims. How did the largest randomized controlled trial in women's health history get the science so wrong? The trial didn't actually disprove hormone therapy's efficacy. Rather, the specific parameters of the study produced results that stood in direct opposition to decades of prior clinical research. To practice true evidence-based medicine, we have to look past the original headlines and deconstruct the trial's design to understand the mechanism of its failure. The stated written objective of the Women's Health Initiative was to evaluate the primary prevention of disease in healthy menopausal women. This visual matrix represents the 160,000 women in the cohort. The first major flaw emerges when we look at age. The median age of a participant was 63 years old. Age 63 is more than a full decade past the biological onset of menopause. Only 10% of the women in this study were actually in the 50 to 54 target age range. The vast majority of the cohort, nearly 70%, were between the ages of 60 and 79. Then we look at baseline physical health. Fully 70% of the participants were classified as overweight or obese. Nearly half were current or past smokers, and 36% were being actively treated for hypertension. The segment of genuinely healthy women entering menopause in this study was statistically negligible. Generalizing these results to all menopausal women is scientifically invalid. The WHI actually studied a senior population with established cardiovascular risk factors. This distinction matters because of a physiological principle the WHI ignored, known as the timing hypothesis. This split-screen timeline illustrates the baseline mechanism. When a woman initiates systemic estrogen in early menopause, the hormone acts on a healthy endothelium, the inner lining of the blood vessels, helping them expand smoothly and preventing atherosclerotic plaques from forming. Now look at the WHI cohort. Here we are initiating estrogen therapy in 65-year-old arteries that already possess established silent atherosclerotic plaques. In these older diseased vessels, introducing a sudden surge of systemic estrogen acts as a prothrombotic agent. The chemical stress physically destabilizes those existing plaques and triggers immediate clot formation. Independent reanalyses of the data, including a prominent 2004 review, confirmed exactly this mechanism. The increased risk of cardiac events in the WHI occurred exclusively in women who were 20 or more years post-menopause. Estrogen does not cause heart disease. The WHI trial inadvertently proved that chronological aging reconfigures how vascular tissue responds to hormones. These biological flaws were compounded by statistical ones, specifically the deliberate conflation of relative risk and absolute risk. Consider this array representing 10,000 women. When assessing breast cancer mortality, the WHI reported 2.6 deaths in the hormone replacement group versus 1.3 deaths in the placebo group. The absolute difference was a mere 1.3 additional cases per 10,000 women per year. That difference was so minute that it failed to achieve true statistical significance. To find reportable hazards, the investigators utilized a practice called data mining. They drilled down into isolated subgroups, such as women who had taken hormone therapy prior to the study, just to extract nominally significant numbers. Those microscopic absolute numbers were then mathematically converted into large relative risk percentages to fuel the press releases. The resulting clinical panic was driven by statistical amplification and a biased search for significance rather than a genuine epidemiological hazard. The clearest resolution to this anomaly comes from an 18-year longitudinal analysis of the WHI cohort. What emerged quietly contradicted the original panic. There were no excess deaths from breast cancer, no increase in cardiovascular mortality. In fact, no rise in overall mortality in women who took hormone therapy. Even more striking, women who received estrogen alone showed nearly a 40% reduction in breast cancer mortality. And those on combined therapy, no statistically significant increase in death rates at all. Beyond WHI, real-world data told a similar story. Large population studies, including nationwide analyses, found that breast cancer mortality was significantly lower, nearly 50% lower in women using HRT compared to non-users. So what actually changed? Not the hormones, but our understanding of them. Because when researchers looked deeper, they discovered something critical. It wasn't estrogen driving the risk, it was the type of progesterone. The original WHI trial used a synthetic progestin, medroxyprogesterone acetate, a molecule structurally very different from the body's own progesterone. And that difference mattered. Synthetic progestins were found to stimulate pathways linked to breast cell proliferation. In contrast, natural micronized progesterone showed a very different biological behavior. No abnormal proliferation, no increased risk in the early years of therapy, and a significantly safer profile in observational studies. The divergence didn't stop at the breast. Synthetic progestins were associated with vasoconstriction, thrombotic risk, and adverse cardiovascular effects, whereas natural progesterone demonstrated vasorelaxation, metabolic neutrality, and even potential cardiovascular benefit. So what was once presented as a uniform risk was in reality a molecular distinction that had been completely overlooked. And that oversight may have shaped 2 decades of fear. This Kaplan-Meier survival curve tracks the cohort over 18 years. It shows that women who took hormone replacement had 0 extra deaths from heart disease, breast cancer, or all-cause mortality compared to those taking a placebo. By 2019, the WHI investigators formally reversed their stance, stating that hormone therapy is the most effective treatment for managing menopausal vasomotor symptoms. They also confirmed its unique efficacy in preventing osteoporotic hip fractures. The WHI data never overturned the protective benefits of estrogen. It proved that late intervention in an unhealthy population is a flawed clinical strategy. Contemporary data synthesis firmly validate the timing hypothesis. The modern clinical consensus is absolutely unequivocal. Hormone replacement therapy initiated before age 60 or within 10 years of menopause significantly reduces coronary artery disease and overall mortality. The 2002 fallout illustrates the consequences of prioritizing a specific trial structure over biological context. We now have the data. We have long-term outcomes. We understand where the risks truly lie. So the question is no longer, is hormone therapy dangerous? The real question is, are we still denying women a therapy that could improve and even protect their lives because of a misunderstanding we've already outgrown? Because this isn't just about hormones. It's about informed choice. and the right to better health.